Kindly let me know when you're able to see. I'm just trying to reshare.
Yes, doctor, we are able to see your presentation now. Thank you so much. You can proceed.
Apologies for that hiccup. As already stated, that for us to build up our case, we're going to have a brief background of just a few keynote words in our presentation, starting with the cervical cancer disease burden in Zambia. As stated, as of 2024, according to WHO, the incidence of cervical cancer disease is at 71.5 per 100,000 women, which is putting Zambia at the third highest in the world, not just in Africa. That is third to Eswatini and Malawi. So with this increased burden of cervical cancer, the government has scaled up increased awareness programs, which has also led to more women attending these screening services. As more women are attending these screening services, we are now seeing more pre-malignant lesions that are being detected, which are now being subjected to a procedure called electrosurgical excision procedure, which is a widely acceptable tool that is used to address pre-malignant lesions of the cervix to prevent their progression into cancer. So we're going to look into it a bit more further into the discussion. So the main indications for LEEP, just to mention the main ones are one, the histologically confirmed CIN2 and CIN3, persistent CIN1, which for more than 2 years, as we know that mostly for HPV infection and CIN1, they should be able to clear within 2 years. So if you have a persistent CIN1 for more than 2 years, it is subject to LEEP. The third one is high-grade cytology with colposcopic findings suggestive of CIN2 or CIN3, as well as adenocarcinoma. So while LEEP in itself is effective in preventing cancer progression, it doesn't come without risks. And I must state here that this presentation does not in any way discourage the use of LEEP, but it just seeks to highlight the importance of recognizing and managing complications like cervical stenosis, which are a potential long-term sequelae of the procedure. And moving on to cervical stenosis, according to RCOG, this is a condition in which the cervical canal narrows or completely closes off, either congenitally or acquired. And for the purpose of this presentation, we are looking at the acquired causes, in this case being the LEEP procedure. So the current incidence of stenosis following LEEP is at 1.3 to 19%. So this is just a pictorial view showing the procedure in itself. So for those that may not be aware or have never seen this procedure being done, so this just showcases the cervix itself. As we are aware, the cervix has two parts, which is the endocervix and the ectocervix, constituting of two different epithelium. Of one is being columnar epithelium and squamous epithelium, and their junction point is an important zone, which we call the transformation zone, which is a very crucial area that from where most of the pre-malignant lesion arises. So this loop has a wire that is able to excise through the cervix and mostly through the target is the transformation zone. And this transformation zone usually depends on the premenopause, the menopausal status of a woman, and sometimes age and parity. So some may be more deeper, and while others may be shallow. Some transformation zones may be shallow. So we'll be able to learn more from the expert as he will go further into discussing this very procedure. So there are a few cases that have been recorded in literature about cervical stenosis following LEEP. And most recent case recorded is in the United States, George Washington University Hospital in 2025, and Malaysia, which is in Melaka Hospital 2023. In both of these cases, the clients presented in a similar fashion with severe excruciating pelvic abdominal pain that required IV analgesia and were treated accordingly. And we're going to learn more about the treatment as we go into the presentation. So with these few background, I now present to you a case of cervical stenosis presenting with hematometria post-LEEP. So this is a case of a 27-year-old para-3 mother who was RVDR on therapy. She presented with a 6-month history of intermittent worsening lower abdominal pain and a 2-year absence of menstruation post-LEEP. The pain was said to be localized in the suprapubic area, was associated with mild abdominal distension, but there was no fever, vomiting, or diarrhea. She had 3 uncomplicated vaginal deliveries, with the last being 3 years prior to her presentation to our facility. The examination reviewed that she was stable, she was afebrile, was not in any obvious distress, there was no pallor, no jaundice or cyanosis. The chest and cardiovascular exams were unremarkable. However, the abdominal exam reviewed a suprapubic tenderness, a soft abdomen, and a palpable uterus at 14 centimeters with free adnexia. The speculum exam showed a short cervix with a closed os, normal vulva and vaginal walls. There was no discharge or bleeding, and there was a positive cervical motion tenderness. So this is just a picture of the cervix on examination. So we further on went to manage this patient as a case of secondary amenorrhea, secondary to cervical stenosis, post-LEEP or loop electrosurgical excision procedure. And the patient was cancelled on the condition and the need for cervical recanalization, of which she was agreeable and gave consent for the procedure. So the baseline investigations that were done, as in any case of amenorrhea, the Gravindex was done, which was negative, so pregnancy was ruled out, and full blood count was normal. Pelvic scan reviewed a severe fluid collection in the endometrium, and LEEP histopathology results, which were followed up, showed CIN3 with normal ages. That was way after the procedure was done. The patient was then prepped and taken in for recanalization on under spinal anesthesia, and dilatation was commenced through a small incision that was made into the cervical os, and followed by use of cervical dilators from size 3 to 12. So I must mention from before I go any further here that this client, before presenting to our facility, had been to several clinics where she was just treated with analgesia, and at some point was treated as a PID, and had been with this pain for over 6 months, as already alluded to. So in theater, we evacuated about 500 ml of dark colored blood from the uterus, after which a size 20 Foley's catheter was placed into the cervical canal, and the catheter was cut short and secured to the lateral wall of the vagina using chromic catgut 2. So these are the images here, or I must state that ethical clearance was granted by the hospital for publication. So on the first image there, that is the image of us evacuating the uterus, and that's the odd blood that was that filled up that kidney dish. And on the second picture, that is after the evacuation was done and the Foley's catheter was put in situ and secured to the lateral wall of the vagina so that it can be secured. I must state here that the balloon was not inflated, so what we just used was the caliber of the catheter just to keep the cervical canal patent. So the patient was then covered on antibiotics, analgesia, some fluids, and the catheter was to be kept in for 2 weeks. Patient was stable on day 1 and had minimal bleeding. On day 2, patient was discharged on oral antibiotics with catheter in situ. After which, on her first review, that was 7 days, on day 7, she came with no complaints, and examination was unremarkable, and the catheter was still in situ. So this was on day 14, on the second review, where we removed the catheter. As previously shown, this was on the first image here. This was the cervix before we did any intervention, And on the second picture, that is after we remove the catheter. As you can see that on the second picture, the cervical os is obviously patterned as opposed to the first image. And below here is the message that was sent to one of our team doctors by the husband to our client, thanking the team for the wonderful work that they had done. So this just highlights that the clients that we see presenting with different complications such as cervical stenosis, which we termed as a silent obstruction because it took a while before she could present to the facility. Remember, we mentioned in the presentation that she had this procedure done 2 years prior to her presentation to the facility and started having these low abdominal pain 6 months prior. So the well-being of the woman doesn't just affect her, but it affects it can affect the entire community, which includes the family, the family and her day-to-day living. So this very simple, seemingly simple procedure was able to improve her quality of life and was able to return to full function, as we can tell from the excitement of the husband from the message here. So our message then, our recommendation from this short presentation is that earlier and more frequent reviews with possible mechanical dilatation are to be employed to reduce the occurrence of cervical stenosis. So there is a study that was done. The reference has been put under the references. You can refer to it. There was a study that was done, a randomized controlled trial where there were 2 groups of women that had just undergone the LEEP procedure. So half of the group was subjected to what they call elective mechanical dilatation at the 3rd, 5th, and 8th week, whereas the other group was not subjected to any mechanical dilatation. And the conclusion from that study showed that the group of women that was subjected to mechanical dilatation had a lower incidence of cervical stenosis occurring after the procedure. So from this, the current recommendation currently, because of that study, has been to be able to book our patients for mechanical dilatation at specific times or weeks post procedure, so that we may prevent the occurrence of cervical stenosis. There was another system that was developed, although it has now been phased out because it was shown that the incidence of the prevalence of development of cervical stenosis post-LEEP had not significantly reduced, and that is what was called the DUDA system. So you can find time to just check what that is about. But it was an endocervical device that was used to insert immediately after the LEEP procedure. It was a device that was put in the endocervical canal to keep its patency. And the other recommendation is that patient sensitization on complication of LEEP to encourage early detection and treatment. So when we are the first responders or the caregivers or service providers of such an important tool, it's also good to be able to give thorough explanation as to what complications may be anticipated, so that our patients can be able to present early and know what to anticipate, so that they can receive proper treatment in good time. As we had stated from our case presentation, that this client had been back and forth from local clinics where she was treated for PID at some point. But if this was picked early enough that the symptoms that she was having, the amenorrhea and the low abdominal pain, were as a result of cervical stenosis and the accumulation of menstrual blood in the uterus, she could have received that treatment, the much needed treatment, way ahead of time. So in conclusion, this case, therefore, it underscores the need for vigilance in post-LEEP patients presenting with amenorrhea and pelvic pain, as well as and early diagnosis and intervention, such as cervical recanalization, are crucial to restore the normal function and prevent complications. So as stated in the presentation, that approval, ethical clearance was given by the hospital to publish this case presentation. And of course, I would like to acknowledge the team of doctors that was involved in the management of this patient as well. And these are my references. And from our presentation, it's good to note that a successful procedure is not only measured by treatment delivered, but by complications anticipated and prevented. I thank you.
Wow, wow, wow. Thank you so much, Dr. Teckra Mazwanga, for that insightful presentation. Actually, I was just starting to enjoy the presentation because, I mean, it was so, so nice only to realize that we had come to the end of the presentation. Wow, thank you, Dr. Teckra, for that presentation. We will now move on to the expert reflections session. After which we will have a Q&A session. Again, colleagues, I encourage us to leave our questions in the chat box, having followed the presentation. And also, if you have any comments about the same, please feel free to share your experiences in the chat box, as I will be following the conversations there. Without wasting any more time, dear colleagues, we are very fortunate to have with us today Dr. Kadisha K. David from Zambia. Dr. Kadisha is an experienced obstetrician and gynecologist with over 18 years in practice. Dr. Kadisha graduated from the University of Lubumbashi in 2006, moved to Zambia in 2007, and obtained his master's in obstetrics and gynecology from the Zambia College of Medicine and Surgery in 2023. He is currently serving as an acting consultant at Levy Mwanawasa University Teaching Hospital, and he is doing a specialized training in urogynecology with the Fistula Foundation currently. Dr. Kadisha will be giving us his expert reflections on this case. Dr. Kadisha, over to you for your expert reflections on this very important case. Thank you.
Thank you so much. Good evening, senior colleagues. Good evening, colleagues. Let me simply say, ladies and gentlemen, okay? So it's a privilege, honor for me to be among you. So I will simply start by saying that, okay, why did we pick this topic? We need to understand that even though cervical cancer is a preventable disease, about 350,000 women over the world suffer from cervical cancer. And if you look at the actual picture, 90% of those women, 90% of death occurs in middle-income countries, and especially in Africa. So whatever we are going to discuss today, you can find it in the IARC, that's International Agency for Research on the Cancer, which is part of WHO, and some of the research is as soon as early as 2025. I mean, 2025. Those are the latest data that you can get if you just go on WHO and search for the International Agency of Research on Cancer. You get all this data we are talking about. So that's why there's no need for me to give you any reference. If you just go in, you will find it. Now, when it comes to Zambia, what happened is we have about 5.75 million women at high risk of cervical cancer, and this is the latest data done by one of our senior colleagues here in Zambia. And imagine we started in 2006. That's 2006, with only one single cervical cancer screening clinic, and that's at our main university teaching hospital, known as UTH. So from 2006, with one single cervical cancer clinic, we are now talking over 300 clinics. And that says that's in 2023. I'm sure by now we've even gone beyond that. So if the more than 300 clinics, we are now able to reach 1.9 million women, and that's about 30% of coverage. For a country like Zambia, with the number of patients we have, this was a tremendous achievement. I mean, a big achievement, and that has to be noted. So, what is LEEP? What is LEADS? Because that's what you hear most of the time, LEEP, LEADS, okay? And this particular case came as a result of a complication of something known as LEEP. So LEEP and LEADS are literally the same thing, okay? So American have tendency of calling this procedure LEEP, and people living in the UK usually refer to LEADS, and LEEP stand for loop electrosurgery excision procedure, and LEADS stand for large loop excision of the transformation zone. So we need to understand that these are excisional procedure that's done for precancerous lesion of the cervix, usually known as CIN, or cervical intraepithelial neoplasia. Now, in Zambia, in particular, we have opted for LEEP because it's very effective. Okay, it allows you not only to deal with the lesion, but also to collect a biopsy, which you can easily take for histopathology and come up with a diagnosis. So it's highly effective, less complication, and you don't need sophisticated instrument or equipment for you to carry a LEEP. A small clinic, a nurse who is qualified, a doctor, basic instrument, you're able to carry out a LEEP. So it's very easy and it doesn't require a lot. And this is why it's the most common used treatment for cervical cancer in Zambia. So by electrosurgery, what we mean is we are literally using electrical current to cut and achieve hemostasis. Someone will ask me, okay, how does electricity going to cut and achieve hemostasis? Of course, what happened with the electrode that we're using, we're going to increase the temperature over 100 degrees Celsius. And that temperature is going to lead to an explosive vaporization of intracellular water, and that leads to tearing tissue apart. And by coagulations, by hemostasis, there are different methods to reach coagulation. You can go by drying, okay, the blood direct contact, or you can do what we call, you can achieve it by desiccation, and there's something known as figuration. So it's more like a cauterization without applying a direct contact on the lesion. So that's literally what the LEEP is all about. So it's cutting and cauterization. So who are the patient that we pick to say, okay, this patient is actually eligible for LEEP? Because that's what we do. We don't just take any person with suspected cervical cancer, cervical CIN or LEEP. And mind you, for us, the LEEP is only done for CIN. We do not do it for cancer. We have a dedicated institution that deal with cervical cancer, which is known as cervical cancer, not cancer disease hospital. So all our patients that we have made a diagnosis of cancer are directly sent there. So when it comes to our hospital, Levy, Mwanawasa, and the different hospital around the CDH, what we do, we do LEEP only for cervical intraepithelial neoplasia, which is CIN. So for us to select the patient for LEEP, we need to make sure that we are dealing with CIN only, no cancer. And even if there's a lesion that is visible after you've applied your vinegar, it's not something that should be supposed to be bigger than 15 millimeter if you do the measurement. This patient shouldn't have some sort of bleeding disorder or uncontrolled blood pressure. This is absolute contraindication for us. We do not do LEEP on pregnant women, even though some books talk about doing it. You can do it if it's less than 3 months, but for us, all pregnant women, it's completely no.
Sorry, Dr. Kadisha, I think you muted.
Okay, am I audible now?
Yes,
Hello?
sure. Yes,
Okay.
doctor, you're audible. You can proceed.
Sorry. So I was talking about the people that we actually pick for LEEP. So I say we only do it for CIN. We do not do for lesion that is above 15 millimeter. We do not do on patients that are bleeding disorder or uncontrolled BP. We do not do it on pregnant women and not when there's active infection. So what are the requirements for you to carry up a LEEP? So with what you need is a colposcope, okay, for you to be able to do colposcopy. You need what we call an electrosurgical unit. You need a return plate. That's a rubber plate, rubber flat thing that you put under the patient. It's literally what we do when you're doing a cauterization, okay? Usually we use either metallic or a rubber plate that you are going to put under the patient in contact with the skin. So we need those loop electrodes. Dr. Mazwanga had the opportunity to show you a picture and you saw something which looked like a loop. So there are different type of loop electrodes. So
Dr. Kadisha,
yes.
Is it possible for you to turn your video on? I'm just asking if it's possible.
Yes, it is. It is. It is. Okay.
Thank you.
Okay. Let's see. Am I visible now?
Yes, you are. Thank you, doctor.
Yeah. So I was saying the different type of electrode, and then it's advisable that you have all sorts. I mean, because usually you need about 4 or 5, if I'm not mistaken. And then there's a 20 by 80, 20 by 4, and then 10 by 4, 10 by 8, and 10 by 10. So usually that's what you need, because of course not all cervix are the same, and then you may have a larger lesion and small lesion, so you don't have to use a bigger for a small lesion. So it's important to have different type of loop electrode. So you need a speculum, okay? And what is recommended is what we call insulated speculum. So it's a speculum that is like a bit of plastic around it, which prevents electricity to go into the rest of the body, okay? So the electricity that you're using is supposed to be applied only on the cervix. So if you have a metallic speculum in contact with that electrode, that can literally electrocute your patient. And that's something that you don't want. So for those who don't have insulated speculum, what we do, we use a female condom that you wrap around your speculum and you insert it. So you need a grasping forceps, you need some local anesthetic, usually 2% lignocaine, and some adrenaline. You need formalin as well. You need a solution known as Morsel solution or Morsel solution, which is something known as ferric subsulfate. It's a cauterization gel that you can apply on the cervix. Okay, and then you need the sponge holding forceps because it's recommended that whatever tissue you are going to excise, you shouldn't use, because what happens is usually people use again the same loop to collect the tissue that you've excised, and that's dangerous because by doing that you can be using active wire and then cause more burning. So it's better that you have a forceps that you can use to collect the tissue as well. So we need a smoke evacuator, which in the majority of our clinic we do not have. Of course, you may need a needle holder and some Vicryl O2 in case there's an active bleeding which you can see and you want to suture. You need some cotton swab and of course, what I said, latex condom. Okay. What is the step to the procedure? So usually, of course, it's important for us to obtain informed consent. The consent is important, especially when you come to Zambia. We ask all our patients to have a consent. A consent is must have. Then, of course, your patient is relaxed in a totomy position. You insert your speculum. You apply a bit of acetic acid. If you don't have acetic acid, like the actual acetic acid, you can go ahead and use vinegar. In most of our screening rooms, we use vinegar because we do not have acetic acid. So it's also recommended that you use Lugo iodine, which in majority of our cervical cancer screening, we do not have. So we just rely on the acetic acid. So once you've done that, the next thing is to apply a bit of local anesthetic and you go ahead and do what we call a one-pass excision. This is one of the methods we use to do an excision and get remove the area which is affected. Recommended depth is about 5 mm at the beginning. You can go a little bit deep when you reach in the middle. Do not exceed 15. Then when coming out, another 5 mm. This allows you to avoid a lot of complication. So we don't just start with a deep, you push your loop deep inside of the thickness of the cervix, then you just do one pass. So the initial cutting should be a little bit shallow. Then you go deep, and then you end up with another shallow excision. If you do that, you avoid the same complication that we've just been talking about, which is cervical stenosis. So after that, you do a bit of coagulation, whether direct contact or coagulation, and then after that, of course, you don't want to do excessive cauterization, because excessive cauterization is also a risk factor for the stenosis. So the next things you do is to apply a bit of a Moncel solution. And in the majority of our clinics, cervical cancer clinic, we do not have. And that is also one of the contributor to complication that we can usually have in our clinics. So that was about the LEEP. What is the most common modality screening, or the method of screening in Zambia? What do we do to screen our women? We talked about 7.5 million of women in Zambia at risk of cervical cancer. So when they come in our facilities, what we do, the most common way of screening, we do what we call VIA, which is visual inspection with acetic acid. Like I said, we usually don't use acetic acid. We go. Then, when it comes to our particular hospital, where me and Dr. Teckra, the previous presenter, work, for us at Levy Mwanawasa, like in 2025, we had about 180 cases of LEEP, and that was done for CIN1. Mind you, we do LEEP for CIN1, even though it's not usually recommended by WHO, because the CIN1 that we incorporate in the LEEP treatment is because it's usually difficult to follow them, as long as we cannot do the follow-ups. So what we do, as soon as we detect something unusual, we just go ahead and do the LEEP. We do what we call see and treat, and that's the way we go about it. So we had about 180 cases, that's in 2025. And the major risk factor for the CIN in Zambia, it's HIV related. And among the patients that we saw, between 20 and 25, that was the age distribution, and the majority between 30 and 50. So this is the case, the number of patients that we deal with at Levy Mwanawasa. And this year so far, we've done about 80 cases of LEEPs, which is significant. I'm sure by the end of this year, it will even be bigger than this. So what is cervical stenosis? Like the previous presenter said, it's a very rare condition, very case of complication. And cervical stenosis can be either complete or partial. Yes, and the mechanism or the pathophysiology behind it is that you've gotten a big shrunk of the cervix. That's when the cervix is healing. Now it's healing with scars, with fibrosis, and that is one of the reasons why you end up with this. The other situation is when you've used too much of cauterization that you've caused some sort of thermal injury. You know, you've burned so much tissue that among the tissue that you've gotten, you even went into the cervical canal and caused some sort of obliteration. And usually the patient at risk of cervical stenosis are women above the age of 50, menopause women mostly. And then, like I say, when you've gone so deep with your excision that you've gone beyond 15 millimeter, and you've gotten a big shrunk of the cervix, and that's usually the most important risk factor. The other one could be also, like I said, excessive cauterization, or you've done so multiple pass excision. Remember, the recommended one is just a single pass. So you demarcate your transformation zone properly with use lignocaine. It's better to use your local anesthesiist to demarcate the area you're going to remove, then using the actual electrode. People who do with the electrode, they'll burn a little bit around the cervix, around the transformation zone, for them to be able to trust nicely the margin of tissue that they're going to remove. And that is really not recommended, because with that you can cause more blood, more lesion, and that can cause other complications. So it's better when you are infiltrating your lignocaine, use that lidocaine to demarcate the area and the margin that you're going to excise. So how do we make the diagnosis of cervical stenosis? Of course, this is a patient that will come to you whether complaining of amenorrhea, if it's a complete obliteration, or hypomenorrhea if there is a little bit of passage. But the majority of them will have some sort of dysmenorrhea, especially if it has the blood has been accumulating into the inside the uterus for so long, and has caused what we call hematometria. Some of the cases which has been talked about is case of infertility. Of course, this is a patient that usually doesn't come to complain, because no symptoms, no pain, but after the LEEP, have been trying to conceive and nothing is happening. And some of them will come for you for cases of infertility. So how do we go about it? Of course, when you suspect stenosis, do your physical examination. The speculum sometimes can be revealing, sometimes you won't see nothing, okay? Especially if a young lady like 20 and above, sometimes there's nothing. So the next thing, if you're suspecting she's in pain, she's not passing you, she's not having a menses, you can do an ultrasound scan. An ultrasound scan sometimes is actually what you need to make the diagnosis. And once you make the diagnosis, the next thing is intervention. You go ahead and proceed with the treatment, which is to restore patency. But the gold standard for this particular case is what you call hysteroscopy. It's just unfortunately that's the majority of our hospitals, and especially where we work, we only have one hysteroscope, which is only kept under lock and key for special cases. So it's not something that you can do like you see in Europe. It's done in OPD as a routine procedure. So for us, hysteroscope is still something that needs special skills, needs special cases. So we do not do it routinely like any other. So ultrasound scan is enough for you to make the diagnosis. What's the management? What's the principle of management? So the idea here is you usually have to balance between the oncologic safety and the preservation of fertility. And the best way to go about it, of course, you want to restore patency, relieve the symptom, and make sure that you individualize the treatment according to the need of the patient, according to the age, according to the fertility desire, whether she's symptomatic or not, or whether she's menopausal or not. This is how you do it. It's not something that you individualize, you generalize for each and every patient. So the treatment has to be something that you do based on the patient that you're dealing with. And the most recommended treatment for this particular case after the LEEP is dilatation. You can use the Edgar's dilators or the Pratt dilators, which are literally the same. And the dilatation, the size that you want to reach usually is between size 8 of the Edgar's dilators to about 10. Okay. Of course, if you want to use the hysteroscope, for you to be able to push the hysteroscope inside the uterus, what you need is about 6 to 8 mm, which is enough. Okay. So there's also a role of applying estrogen cream. Okay. Especially in premenopausal, in postmenopausal women, because estrogen, what it does, it's allow the cervix to remain a little bit flexible, and it's allow a good recovery after that. And when it comes to Zambia, there's special consideration when it comes to Zambia, for example. Why do we have these complications, not only what we discussed, which is the stenosis, that we have seen several complications when it comes to the provision of treatment of cervical cancer in Zambia. Some of this is, of course, linked to the fact that we have a huge number of patients suffering from precancerous lesion and cancer. So that means we have a huge number of patients coming to our clinics. There's also a constraint which is related to resources. We do not have most solution most of the time. Majority of our
don't say that.
the majority of our clinics.
Red, green, and red. These are all the ones.
The majority of clinics, should do this procedure without a magnifier.
Hello, Carol, kindly mute. Thank you.
Yes.
Yeah. So we don't have a colposcope to increase to magnify the area where you want to operate, and that can allow you to remove the exact area which is affected. So we do not have. So we just use our spotlight, a good light, and then we go ahead and do the LEEP, and that's also one of the risk factor to complications. I think as an expert and what I prepared for you, this is what I had, and then of course feel free, we can discuss and interact. Feel free to ask questions, and we'll talk. We'll try to discuss and see how we can explain what we do. Most of the time is what I'm trying to explain to you is what we do here in Zambia and with what you have, and then I'm sure it's usually the same everywhere else. Otherwise, I submit. Thank you so much.
Wow. Thank you so much, Dr. Kadisha K. David, for those very practical and valuable insights. We will now move to the Q&A session, and I will start picking questions from the chat. Looking at the chat, we have very interesting questions from the participants. And I will be forwarding these questions to you, Dr. Kadisha, so that we can clear this. Someone in the comment was asking, what is the best mode of delivery for a mother post-LEEP cervical stenosis?
Okay. We get some other questions, or I can just go ahead and trying to answer the question.
Yeah, I think it's better we do as I pose the question, you respond, then I ask the next, like that.
Okay, yeah. So post-LEEP, because what we've discovered is whenever you do a good LEEP, even those who have active infection of HPV infection, usually when you get the margin right, within 6 months, when you do the HPV DNA testing, usually they come out negative. This is also supported by research done. I can't remember the year, but there's something. If you do some research, you'll find there's some studies which was done, and then as long as there's no active HPV infection, vaginal delivery is what is recommended. Of course, patient after LEEP, some of them will complain of some sort of cervical incompetence, but which is very rare. And then some have recommended sacrilege before, but in our practice, whatever we've done, we've never seen the need of putting cervical sacrilege. So we just do a close monitoring during antenatal, and then we allow them to deliver vaginally.
Okay, thank you, Doctor. The next question is, how can cervical stenosis be distinguished from menopause in women presenting with amenorrhea? Also, on that, you mentioned that ultrasound scan is an investigation that could help reach the diagnosis. So another question, someone is asking, what ultrasound findings are most suggestive of cervical stenosis in this case? Thank you.
So, sorry, I didn't get the first question. The first
Okay,
question
the first question is,
Mhm.
yes, the first question is, how can cervical stenosis be distinguished from menopause in women presenting with amenorrhea?
Yeah, so of course, cervical stenosis, of course, you can see it after 50, but like I said, the majority of patient that you are going to have is something must have been done. And in this case, mostly this patient is post-LEEP. Okay, and you can see it as early as 3 to 6 months after LEEP. Okay, yeah. So in the cervical, in cervical stenosis, you are not going to have things like odd flashes. Okay, things like brain fog, fog, or things like dryness of the vagina or vagina pruritus or painful sexual intercourse, because you're still producing your estrogen. As long as you're producing your estrogen, you're okay. The only thing here we are going to see is that sometime, if it's complete, there'll be no period. But if it's complete, if it's incomplete, there could be some period. Okay, yeah. But in menopause, we're looking at the age. The majority of them, we said menopause start from 45 to 50, and we said 50 plus 1, because there's always that 1 year, which is important for us to make the diagnosis. So in menopause, you're usually dealing with a woman who is at least 45 and above. In this case, apart from the fact that they are not bleeding, there are other symptoms. And the most common symptom is odd flashes, from nowhere. It's cold and she's just been busy fanning. Okay, you also have other complaints like, okay, mood swing, and then painful sexual intercourse, risk of osteoporosis and all these things. And if by any chance you decide to do follicular stimulating hormone level, you'll find that in the case of cervical stenosis, your FSH should be within normal. Okay, there should be any elevation on FSH. But if you do it on a woman who's menopausal or postmenopausal, you find that your FSH will be very high. So this is usually how you make the difference. Now, what will be the findings on ultrasound scan? Of course, the most direct, but the most important finding that you're going to see on ultrasound is just some fluid in the endometrial lining, and that fluid should be significant enough to tell you, to say there's something. There's no passage on there's no passage of the menstruation blood, which is stuck. Okay, and sometimes even during your bimanual palpation, you can feel a bulky uterus if that stenosis has been there for some time, and that's usually what causes dysmenorrhea. Okay, and that's what you really need, because the cervix is completely closed, and usually the closure is at the cervical, the external cervical os. So you can even see some of the fluid in part of the cervical canal, and that also is suggestive of cervical stenosis.
Oh, wow. Thank you, Dr. Kadisha. I see that the participants, everyone is really, really actively listening and following. I can tell from the very many questions that are coming up in the chat box. I will take 2 more questions and we end this Q&A session. Dr. Kadisha, one of the participants is asking, should the excision depth be standardized based on age and fertility desires? As you mentioned that sometimes these are some of the things we consider before LEEP. Should we standardize should the excision depth be standardized based on these factors like age and fertility desires?
Okay, that's a very interesting question. So like I say, the reason why you haven't standardized is because we try to go only for the lesion that you have to remove. Okay, So sometimes, like I say, when you really want to remove the or transformation zone, you can go and do you can get a bigger area, especially if you think that the lesion is slightly above the transformation zone. But if you look at the most common presentation of CIN is within the transformation zone, and the transformation zone depend from a patient to another. Okay, you will find that a patient that is on contraceptive are probably larger transformation zone. A woman who's close to menopause has a very small transformation zone. And then you cannot standardize and say, I'm going to use the same loop for a young lady within a reproductive age and an old lady who's close to menopause. And not only that, because then you need different size electrode. And then some of this CIN, like we say, we do also for CIN1. You find that CIN1 is just a simple, the depth is not too deep, okay? The dysplasia or whatever transformation hasn't reached the basal membrane. So you don't have to go too deep for you to achieve a very good margin. Sometimes just a shallow excision is enough for CIN1, CIN2, like we say, for us, we do even for CIN. So that's why it's very difficult for you to standardize. It's better you do your VRA nicely. If you are able to apply also a bit of lugo-iodine, you identify the lesion properly, you have your colposcope, you magnify the area, and you focus more on that area. Just doing a single pass excision, which is what is recommended, you avoid all these things. I submit.
Thank you. Thank you, Doctor, for that very good response to the questions. Now I will move to the last question. Sorry, if I don't read out your question, just know that the questions are so many and we cannot have them all answered in this one session. So I will take this as our last session for as the last question for tonight. Someone is asking, following dilatation, what is the risk of progression of the cancer stage? I think is asking, is it following dilatation or treatment of cervical stenosis? The question is not clear, but I think he's asking, following dilatation, what is the risk of progression of the stage of cancer?
So there's a study, I think, which was done in, is it Dhaka or somewhere in some capital city somewhere in Asia, where they did a leap, and then there were these for high risk, precancerous lesion. We're looking at CIN2 and 3. Usually CIN1 usually does, when you've done your leap properly, the risk for progression is very little. CIN2 and CIN3, yeah, the results of the conclusion of the study was that you have about, if I'm not mistaken, 15% chance of progression to cervical cancer after LEEP, which I think is good. It's good enough, because 15%, we look at it's 4 to 15%. You look at the risk of cervical cancer itself and the number of patients that is sick. If you can achieve at least, if you can reduce the chance by 15 minus 100, something like is it 76, which is good enough. If you can prevent the risk to cancer about 76%, which is okay. So the study shows that is about 4 to 15% chance of progressing to cervical cancer. That's the study which was done, and it's also available online.
Wow, thank you, Dr. Kadisha K. David, for those expert reflections on the topic. And thank you all those who contributed. Thank you for those excellent questions and thoughtful contributions. Now, today's key take-home messages that I'm getting from this discussion is that Today's session really brought out the importance of early recognition of the complication, cervical stenosis in this case, following the procedure. And also from these discussions today, I believe that we can all agree that the discussions brought out also the importance of careful follow-up after the LEEP procedures and timely management of this cervical stenosis, especially in our settings. Also from Dr. Teckra's presentation, in her conclusion, we could see that the importance of post-procedure counseling could actually help so much in ensuring early diagnosis, because I believe that if this patient had been counseled so well of the anticipated complications, she herself could have actually guided the people that made the diagnosis of PID and all that before reaching this that actually delayed the proper management. So post-procedure counseling is very, very important, so that you tell the patient what are the complications expected, and then when to seek help. With that said, we will wrap up this session, today's session. And before we wrap up today's session, we would like to sincerely thank our amazing presenter for today, and that's Dr. Teckra Mazwanga, and our expert discussant, Dr. Kadisha K. David, for their brilliant contributions. And a special shout out to the WATOG Africa leadership and the entire organizing committee. And right here, I must mention Dr. Collins Simbeye, our WATOG representative for Zambia. Dr. Collins worked tirelessly behind the scenes to coordinate the Zambian team that delivered this great presentation for today. Thank you so much, Dr. Collins. You played a very vital role in making this session a success, and we really cannot afford to not mention you today. Thank you so much to the Team Zambia for this excellent show. And of course, I want to specially recognize someone whose hard work has truly, truly made all this possible. In fact, the success of our continental bi-monthly clinical case series would simply not have been the same without the exceptional leadership, the dedication, and the tireless coordination of Dr. Ida Linda Wanjiku, our WATOG Africa continental representative. From the early stages of conceptualization of this initiative to the execution that we are enjoying right now. Yes, Dr. Ida has been here from the very beginning, right from the idea stage, all the way to what we are enjoying today. She has been the driving force behind this program. She has overseen every single detail with such commitment and professionalism, and I can testify that these are the things that I have actually seen. They really stand out when you just interact with Dr. Ida Wanjiku. So Dr. Ida is involved fully in the strategic planning, the coordination across countries. Remember, this is an African thing, so she coordinates across countries. She developed our moderation and presentation guidelines. She created a standard WATOG PowerPoint template. I believe that you all saw the presentation. Our slide presentation was very, very excellent. And Dr. Ida actually created that standard template for us all to enjoy and use. She does all this while handling the virtual platforms, the access links at the same time. Oh my God, there is a lot. Honestly, she puts in countless hours behind the scenes that most people never really see. And that is a true servant leadership right here that we can see from Dr. Ida, our WATOG Africa representative. Her passion for advancing obstetrics and gynecology training across Africa is just incredible. It is always on her lips and literally in everything that she does. So Dr. Ida Linda Wanjiku, we extend our deepest appreciation and gratitude to you. Thank you so much for everything that you do to make WATOG Africa vibrant as it is. We also want to thank all of you, our wonderful participants and trainees, for um, showing up and making this another enriching and very interesting Pan-African learning moment. And of course, I cannot go without saying this. I want to say a big thank you to the technical support team working behind the scenes to keep everything running smoothly. Team South Africa, we really acknowledge your role in this, coordinating the online platforms and all that. Thank you all so much for this. Now, finally, but before we wrap up, we just have a few quick announcements to pass across. First of all, I just want to remind us that we hold this bi-monthly clinical case series every second Thursday and last Saturday of the month. Please note that we hold these clinical case series, these learning sessions, every second Thursday and last Saturday of the month. So kindly keep an eye out for our upcoming dates. With that said, our next case series is happening on Saturday, 27th of June. That is the last Saturday of this very month. And this time round, we are moving to West Africa. So Saturday, 27th June, Nigeria will be moderating while Egypt, this Saturday, 27th June, Nigeria will be the presenter and Egypt will be moderating. We are really excited to hear these presentations from Nigeria, and we can't wait for our next bi-monthly clinical case series from Nigeria. We also have several exciting conferences, webinars, and educational activities coming up. So please keep engaging with WATOG through our social media platforms. We have a WhatsApp platform. We also have a YouTube platform that carries on these learning sessions. Like I already mentioned from the beginning, that this very session for today is being recorded and will be uploaded to our YouTube channel. So kindly, everyone, I encourage us all to stay connected and follow WATOG through social media, LinkedIn, we are there. So kindly just stay connected with us, and as you watch out for the updates on the very interesting sessions that are upcoming. And also, before we close the session, I want also to remind us all that there are great opportunities for those who would love to present or moderate future sessions. Yes, this is how we get the presenters and the moderators, because as I mentioned from the introduction, is that this WATOG exists to enable us share our different unique cases and experiences. So there are lots of opportunities available to all of us in the future. You can also be a case presenter and you can also be a moderator of these sessions. So please stay connected with us on all our social media platforms, YouTube, LinkedIn, and even WhatsApp for this. And if you would like to present in the future, please just connect with us through social media platforms. With that said, I come to the end of our session. On behalf of WATOG Africa, I want to thank every one of you for joining us today. And surely we are building a stronger and clinically excellent community in obstetrics and gynecology across this continent. Yes, we are building a stronger community across Africa. We look forward to seeing you again at the next session. Please have a wonderful evening. Stay safe and have a great and please keep up with the great work that you are doing in your respective countries. Thank you so much. See you during the next clinical case series. Bye.